Thank you, Sarah, for the lovely introduction, and thank you very much, everyone, for coming. We had a little bit of an issue with the slide sharing, so I hope everyone can see and read my slides. So as Sarah mentioned, I am going to talk about this paper that was published in Biological Psychiatry, and it involves data that were collected at the IOPPN as part of my PhD thesis. So I'm not even going to bore you with the details of how ketamine works, because I know that the audience here is very, very knowledgeable on that. But the reason for this background slide is because I would like to draw your attention to a couple of things concerning ketamine research that might help you better understand what was the rationale behind our study. So as you all know, ketamine is an antidepressant whose actions peak approximately 24 hours after a single ketamine infusion. But the antidepressant effects of the drug are still detectable as early as 2 hours after a single ketamine infusion. And not enough is known about what's happening in terms of changes in brain activity and connectivity between these 2 hours where you first detect the ketamine response up to 24 hours when the drug effects peak. And of course, there is a lot of research, and it's quite exciting actually now to try and keep up with all the ketamine-related information, pointing to the fact that at 24 hours, when the ketamine effects peak, there are some changes in brain activity and connectivity that point towards a normalization of the drug effect. So in depressed patients, changes in brain activity and connectivity that we observe compared to healthy controls seem to normalize and go away 24 hours, even up to, studies go even up to 10 days post-ketamine administration. This is really, really important. And these studies are primarily done on depressed patients, which is great because ketamine is an antidepressant. And if it wasn't such a potent antidepressant, we wouldn't be talking about it now. And of course, the main focus should be on depression. But when studies are conducted on depressed patients, they're usually accompanied by changes in symptoms. And when it comes to interpreting neuroimaging results, there is always the factor to consider that these changes you see in brain activations and brain connectivity could be the secondary effect of changes in symptoms and not a direct effect of the drug on brain mechanisms. So they present with a challenge to interpret. In order to address some of these issues and look in more detail at how ketamine influences reward processing, we designed a study that would look at ketamine's effects on reward processing using the PMID task, which I will talk about and explain in a minute, in a sample of volunteers who remitted from depression. So for this study, we recruited 37 treatment-free remitted depressed volunteers. They weren't on any, to clarify the treatment-free factor, they weren't on any antidepressant medication at the time of the scan, and they were also treatment-free up to 6 months prior to taking part. And of course, they were remitted, so they didn't present with any depressive symptoms. So our patients came in, and at the start, we had a double-blind, placebo-controlled crossover design. So they came in at the start of each session, and they had some pre-infusion checks and a cognitive battery of testing, including, since we are focusing on reward processing, the SHAPS to measure anhedonia. And then they received an intravenous infusion of ketamine or placebo. The ketamine infusion was a very standard infusion that we use now to have the antidepressant effect of the drug, and the dose was 0.5 milligrams per kilogram, and our placebo was saline. And they also did the PSI, which is the psychotomimetic states inventory to measure the psychotomimetic effects that ketamine might produce during the infusion. And after 2 hours, they were having an MRI scan, and they did a resting state scan, and they also performed the MID task. At the end of the scan, the patients were discharged after having a short post-MRI cognitive battery and repeating the anhedonia scale one more time. So just to explain a little bit our experimental design in a bit more detail, I think I've already touched upon why 2 hours post-ketamine infusion, because we know a lot about the 24 hours, or at least we know more about the 24 hours. And we wanted to see whether the pattern of brain activity and connectivity that we are going to observe at 2 hours is similar to that we see at 24 hours after a ketamine infusion, or whether they are completely different and the earlier antidepressant response of the drug is different to the one, to the peak one. And we chose volunteers who remitted from depression because, of course, they are medication free, and we don't know the long-term effects, if any, of antidepressant medication on the brain to account for them properly. And of course, there was the absence of depressive symptoms, which allows us to be more confident to say that when we observe any changes in brain activations, these are most likely due to the ketamine and are not an effect of symptom changes. But individuals who remitted from depression are not quite like healthy controls. We know from the literature that even patients who remitted from depression still present with some of the characteristics, in a way, of brain activity that depressed individuals have. So we know from the literature that they have, for example, overactive amygdala when it comes to responding to emotional stimuli, or that they present with blunted responses to feedback. And we also know that their striatal activity is reduced compared to that of healthy controls. So in a way, using a sample of participants who remitted from depression allows us to model ketamine's effects on reward processing without having while controlling for changes in depressive symptomatology and being completely free of the antidepressant medication effect. So when we designed this study, we had specific regions of interest in the brain that we wanted to look at. And since the study focuses on reward processing, I think it makes sense to focus on the mesolimbic reward pathway and look at the dorsal and ventral striatum, the ventral tegmental area, the insula, and the amygdala. These areas are not only important for reward processing, but they are also important for the MID task. So they are areas that are engaged and activated during the task. And we wanted to see exactly what ketamine's effects on those brain regions would be. And our initial hypothesis was that ketamine would cause an increase in the activation of our regions of interest 2 hours after the administration. And as I will explain later on, the MID task has a feedback phase and a reward anticipation phase, and different rewards are incorporated in the task. So we thought that ketamine's effects would be mostly detectable on the MID trials that are associated with winning higher rewards. Before moving on to the results bit and talking about the effects that ketamine actually had on the MID task, usually it's interesting to look at ketamine's acute psychotomimetic effects, and I thought I would present these as they are part of the paper, and they were also measured, of course, during our study. Participants filled in the PSI, the psychotomimetic states inventory, and we found that during the infusion, there was a significant increase caused by ketamine compared to placebo in the 6 subscales, that the PSI has. So there was a significant increase in anhedonia, cognitive disorganization, delusional thinking, mania, paranoia, and perceptual distortions. And of course, the total score of the scale was significantly higher on ketamine compared to placebo. However, when our participants went into the scanner 2 hours after the ketamine infusion, any of these effects were completely resolved. And we are in this way confident that any changes we see during the task are not due to these side effects of ketamine, but they are most likely part of the early antidepressant mechanism of the drug. So what did ketamine do to reward processing? As I mentioned before, we looked at reward processing by using the monetary incentive delay task. It is a very well-studied task, and this is good because we have a very good idea of which areas we expect to be activated during each phase of the task. And effectively, for those of you who are not familiar with the task, it is a reaction time task. So participants are asked to press the button, specifically the left button in the scanner button box, every time they see this white square, which is the target, appearing on the screen. Before the presentation of the target, cues are presented that are associated with different reward magnitudes, and participants practice the task before they go into the scanner. So these associations between the cue and the target are already learned before participants go into the scanner. So participants know that when they see a circle with one line, they are going to win 20p if they are fast enough in pressing the button when they see the target. They know that when they see a circle with 3 lines, they are going to win £2. And they know that when they see a triangle, they are not going to win anything, but they still have to respond as fast as possible when the target is presented. And there are also some passive trials, which are signaled with the X. During those passive trials, participants are not doing anything. They are just waiting for the next cue to come up, and then they had to hit the next target. So our task had a total of 96 trials, and every trial can be split into the reward anticipation phase, where you can have anticipation of a neutral, a low win, or a high win reward, and the feedback phase. And the feedback phase, which is when participants learn whether they won or not and how much is their total sum of winnings in the task, can be further split into trials that are associated with a win. And for the purpose of this analysis, we call those win trials, and trials where they didn't win anything, which are called no-win trials. And they are not loss trials, which is quite different because no amount of money is taken away from the participants if they are not fast enough. They just do not increase their total earnings. So what we did is we first of all looked at task performance. And performance in the MID task is measured by looking at reaction times and looking at total task winnings. And you can see here that participants perform to the task as they are supposed to. So the high win trials In the high wind trials, they are slightly faster at pressing the button because they have greater monetary value, as you would expect. But ketamine does not change significantly task performance. So the reaction time and the total amount that participants win is no different between the ketamine and the placebo session. I would like to say here that before looking at the effects of ketamine on the brain activation of our regions of interest, we did do a placebo analysis looking at the task at a whole brain level to make sure that the areas that we expected to be activated during the task are indeed active. And engaged by our task. So in a way, this is a safety check to make sure that our task is working properly. And we didn't find that there were activations in the ventral striatum, the VTA, and frontal brain regions for the anticipation and the feedback phases of the task, as you would expect. And then we did our regions of interest analysis. And what we found is presented in this figure panel that I am going to try and explain and maybe just zoom in a little bit in case this helps. So what we found in general, and to our surprise, was that ketamine mostly affected the feedback phase of the task. So from this panel of 6 figures, I am very sorry about this, only one contrast is an anticipation contrast where ketamine had a significant effect, and the rest of them belong to the feedback phase of the task. The crosses you see above the blue lines, which represent brain activity of our regions of interest under placebo, are regions of interest that appear to be significantly activated during this contrast for just the placebo session. And everything that's marked with an asterisk is regions of interest where ketamine produced a significant change in brain activity compared to placebo. This is a lot of regions of interest and a lot of contrast. So we had to be very careful when we did our multiple comparisons correction, and only the regions of interest that are marked with red here in contrast B are the ones that survived the Bonferroni correction. But overall, and as a general picture, we can say that ketamine has a greater effect during the feedback phase of the task. It causes mainly increases in brain activation and of our targeted regions of interest. And these increases are mainly centered in low wind trials and no wind trials. And this is quite surprising because if you remember from our hypothesis, we were expecting that ketamine is going to have a more profound effect on the high wind trials compared to low wind or no wind trials. Just to show you in a little bit more detail, the contrast where ketamine had a significant effect and the findings survived the multiple comparisons correction. Ketamine here produced a significant increase in the activation of the nucleus accumbens and the putamen for when the low wind trials were compared to neutral trials for their feedback phase. And to our surprise, the changes that ketamine produced in the ventral tegmental area for this specific contrast correlated with the levels of hydroxynorketamine. So for this study, we collected blood samples at the right at the end of the intravenous ketamine infusion, and then we collected another sample again 2 hours after the infusion. And as you can see from the bottom panel here, as you would expect, there is a significant increase in ketamine's metabolites 2 hours after the infusion, and the 2R6R hydroxynorketamine levels correlated with the increase in the activation that we see in the ventral tegmental area for the feedback phase of low Wnt trials versus the neutral trials. Now, of course, we were very excited and happy about this finding. I don't think that we should be, this finding needs further replication, and I shouldn't be making too much out of it. However, it is a great indicator, I think, that hydroxin or ketamine, that has been discussed a lot in the literature and debated, and there are some conflicting findings around the role that this metabolite might have for the antidepressant effect. It seems to be at least playing a role for the initiation of the ketamine's antidepressant response, at least 2 hours after the drug administration. And the ventral tegmental area, which is part of the mesolimbic pathway, receives a very dense glutamatergic input, and it is very, hydroxin or ketamine has been associated with initiating by acting directly on the AMPA receptor plasticity-related mechanisms that could then maybe help in building up the antidepressant response that ketamine has 24 hours after the infusion. So to conclude, I think that our paper shows that ketamine increases the activity of areas of the mesolimbic pathway, and these changes are mostly focused on the feedback phase of Wnt and no Wnt trials compared to neutral trials. We know from the literature that patients who are remitted from depression, but also depressed individuals, have blunted responses when it comes to feedback. So it could be that ketamine as an antidepressant would act in a way that would mediate and change the way participants respond to reward-associated feedback. And this is quite exciting if you think about the very important effects that ketamine has on anhedonia, which is one of the very persistent symptoms of depression, and is, of course, linked to reward processing and reward processing deficits. This study has several limitations. We were very much constrained by the absence of a healthy control group when interpreting our results, and we needed to be extra cautious when we did. First of all, the presence of a healthy control group would have allowed us to determine whether some of the changes that we believe are present in the brain activation of our immediate depressed patients and closely resemble that of depressed individuals, such as, for example, the overactive amygdala or the hypoactive striatum. If we had a healthy control sample, we could actually determine for sure whether they are there or not, and that would have greatly strengthened our findings and maybe elucidated even more ketamine's earlier antidepressant mechanism. And of course, the MID task is a great task and very well studied, but it is a task that mainly focuses on the anticipation phase of so the part where you anticipate the reward. We found that most of our findings are centered around the feedback phase of the task, and this was surprising, but it makes us now think that in the next step, if we are to repeat a similar study, maybe we should also include a task that is looking allows us to look in more detail at the feedback phase of reward. That's all from me. Thank you very much for listening. And I would like to take this opportunity and thank my supervisor, Professor Mehta, for giving me the chance to do this work and opening the ketamine path for me. Thank you.
Yeah, thank you so very much. So many interesting data and so much to unpack. Thank you for presenting this so clearly to us all. So that in the meantime, also Dr. Machine was able to join us. But if you don't mind, of course, like invite all our attendees to place any question they may have in the Q&A. But in the meantime, if you don't mind, I may like kick off with some question on my own, and then we can maybe move to the formal setting as well. So first of all, was like really like a technical question. When you say like 120 minutes after the infusion, are you referring like after the end of the infusion, or was like these since the beginning of the infusion?
Sorry, you mean the 2 hours?
Mm-hmm.
The 2 hours, but yeah, it was 2 hours after the end of the infusion. So if you take into account that they had to do some structural scans and then they did a 10-minute resting stay. So we're talking about MID findings 2.5 hours after the end of the infusion. Yeah.
And that's very helpful to know. Just maybe in case like somebody from our audience is not familiar with the MID task, since this was a crossover design, was like any concern of like any potential learning effect?
Well,
task.
The associations between the cues and the targets are already learned, but we had 2 different playlists. So in case anyone was particularly able to pick up and remember the sequences of when there is a lower and a higher Wnt trial and everything. There were 2 different playlists to account for that, so we took that into account.
So you were able to control for that?
Yes,
yeah. And since sorry to speak about this study design question, but like, since this was a crossover, and was there any concern of any potential, carryover effect of the drug, and was like the 2 groups performing differently if they were randomized to ketamine versus placebo in a different order?
We did perform an order analysis. So we did look at the data, taking into account, looking at those who received the ketamine first and those who received the placebo first, to make sure that there was no order effect, and there wasn't. We didn't find any indication that participants were performing differently when they received ketamine first or placebo first. The main concern that we had from the crossover design is I think the concern that most studies have when it comes to ketamine, and it's the blinding, because participants were having a lot of psychotomimetic effects that they were really very keen to report and talk about, and we tried to control for that by having different people present during the infusion, and then sort of giving me a little bit in the dark about what's happening in those 40 minutes and a bit later on. But yeah, but there was no order effect, and the 1 week apart for the 2 sessions, I think, is enough to take care of any medication. It's a washout period that is sufficient to account for ketamine.
And did you have any data on like the participant guess?
The participants, sorry?
Guess what they guessed for the treatment?
Or? We didn't, but from what I've been told, I think that that if we had any data, the percentage would be really high, guessing right about ketamine. Unfortunately.
We have some question in the Q&A that I'm going to ask you. So one of these is from Catherine Harmer. It says, thanks for your great talk. Can you clarify the contrast where you saw the main effect of ketamine? Was it all feedback versus neutral trials, or low win versus neutral, but not high win?
Sure, yeah. Let me go back to that slide, and thank you, Professor Harmer, for the question. I'm not sure I know how to close this though. Maybe here or here, no? So the contrast where the main effect of ketamine was seen was the can you see that? Or
we can.
Yes, yeah. Okay. Was the feedback phase of low win trials versus neutral trials. they were all win trials and not high win. So lower rewards and successful trials, if that makes it more clear.
Then we have another question from Armagan Samanchin. I hope I'm saying this right. Could you tell us about difference in the effects of norketamine and HNK in comparison to ketamine?
Well, I can tell you that when we did the metabolite analysis, we checked about potential, with giving a lot of attention to multiple comparisons issue. We went and looked specifically for hydroxynorketamine because we had the literature around hydroxynorketamine. So we specifically hypothesized that if there is anything, it might be there. There is the correlation between the ventral tegmental area and AIDS and K. In terms of any correlations with norketamine and ketamine on these data, I did an exploratory analysis and we didn't find anything. There's not much more I could say about this. The only thing I can tell you from, and you can see from the graph, is that there is a significant increase in the metabolite level 2 hours after infusion. But when we were looking at correlations between the metabolites and the brain activity, we went very specifically and looked for hydroxynorketamine. So.
We have another question from Ramesh. Is it possible that the MRI mimic TMS? Is it possible that the MRI mimic TMS-like effects? And would you be able to use markers to localize activity?
I'm not very sure I understand this this question right. I don't. In terms of like activations that we would see with TMS, or then we looked at the MID task, which is a reward processing task, and we very, very specifically went and checked at the regions we were interested in. I don't think that there is any likelihood that the MRI mimicked TMS while participants were in the scanner. But again, I'm not very clear about the question either. So,
well, maybe Ramesh can stay on when we into panel.
Yes, please do, and we can talk more about this.
We can discuss a bit more about that. So I'm going to read you one last question before we stop the recording, and then we can move everybody to panelists in the interest of time. So this question is from Dr. Susanna Murphy that says, thanks for this really interesting presentation. The difference between the groups on the low win versus neutral contrast seem in part to be driven by a deactivation in the saline group. Do you have an explanation for why this might be?
This is a very good question, and I agree that there seems to be a decrease in the activation of the of our ROI of our OIs in the placebo session. It is typical that during the feedback of the MID task, you would see a decrease in activation of regions that are part of the mesolimbic pathway. But I couldn't, that's all I can say. I don't think that this is particularly strange for our task findings. We have previous results on the MID with multiple other drugs that sort of have the same profile during the feedback. It could be that participants just, lower their cognitive burden during the feedback phase of the task and they sort of relax. That is why you see all these deactivation. And then ketamine causes an increase and draws more attention to trials that are associated with lower or negative feedback. I think we would benefit again from a control group here to answer this question more fully.
Okay.